Hello, welcome. So, on this case study, we'll be talking about breech. So, here are the following questions. So, question one is a case study. So, question one is saying, mention three types of breech presentation. Okay, and then in the picture in front of you, what type of breech presentation is it? Then, what would you do for antenatally? Then, mention four risk factors for this condition. Then 5, if she presented in her 37th week with this presentation, what would you do for her? Okay, so those are the questions we have been given. Okay, so this case study, we mentioned three types of breech. We have the complete one, a frank breech, and a footling breech. Then in the picture, the the breech is a footling breech. As you can see, there is a foot which is presenting first. Okay, then what would you do for her antenatal if she came antenatal? What would you do for her antenatal? So if she came antenatal and the child is on breech, so we can do an external cephalic version, although for now it's usually not necessarily been advised, so because of the intervention that we currently have. Okay, so mostly we just let them until they come for until they are like seventh week. Okay, that's what you can do. Okay, but for literature's sake, you can do an external cephalic version. Okay, then mention four risk factors for this condition. So we can have prematurity, uterine anomaly, fetal anomaly, hydrocephalus, prior breech presentation, multiple gestation, and of course polyhydramnios. Those are some of the risk factors. Okay, so if she presented in her seventh week, this presentation, what we would do for her is of course the cesarean section. But of course, like I said, literatures and practical are two different things. So if she presented in her 37th week with this presentation, of course we're going to do a cesarean section because it's a footling breech. Same with antenatal, so we can do a ECV. But if for a footling breech, it's best for as someone who comes at the 7th week, footling breech is best for cesarean section. Okay, then for literature review, so you have to know that in breech presentation, the presenting part, of course, are the buttocks normally. So that's the presentation. Okay, presentation are the buttocks. Okay, that's the presentation. And then the incidence is at least 3 to 5%. That's the incidence of breech presentation. So 3 to 5%. Then at or near term, but much greater in the early pregnancy. So it is about 14%. Okay. Then those found in early pregnancy will often spontaneously convert to vertex as term approaches. So the major risk of vaginal breech delivery is entrapment of the after coming head. That's the major risk. Okay. Then we also have risk factors for breech presentation. So risk factors. So risk factors we can put them on the under uterine risk factors. So uterine risk factors we have fibroids, we have uterine anomalies, uterine abnormalities, uterine surgery, oligohydramnios, polyhydramnios, multiparity. Okay, then under fetal risk factors. So fetal risk factors. So fetal risk factors, we can have low birth weight or prematurity. We can have congenital anomalies such as hydrocephalus or anencephaly. We can have multiple gestation. We can have placental previa. We can have neuromuscular conditions. Okay, those are some of the risk factors. Okay, then diagnosis. How do you make a diagnosis of breech? So can be made if you are using the Lopez maneuver, okay, can be made, especially if it's above maybe second trimester, okay. And then you can also make a diagnosis of it using the just ultrasound alone, okay, even VE, okay. So even VE you can make a diagnosis of breech. Then types of breech. So what are the types of breech that we know of? So types of breech, we have frank breech. So frank breech is also known as extended breech, and it's common about 15%. Okay, 15%, that's frank breech. Okay, so frank breech, also known as extended breech presentation, which is the most common type of breech presentation, where the thighs are flexed or bent forward and knees are extended, so straight, okay, and they are over the anterior surface of the body and in front of the head and or face. Okay, so this is the only kind of breech presentation that potentially could be safely delivered vaginally. Okay, this is the only type of breech. Okay, and then for a complete one, so this is the extended frank breech. Also have a complete breech. Complete breech. So for a complete breech or flexed breech, which is common about 25%. Okay, so this is 75%. Okay, so under the under the under the complete breech presentation, the thighs are flexed or bent on the abdomen, and the knees are flexed, folded as well. So they are not straight. Okay, they are bent. Okay, the thighs are bent and even the knees are bent, and it is an unstable breech and can convert itself to a footling breech presentation. That's a complete or flexed breech presentation. Okay, then we have a footling breech. Footling breech. Footling breech, also known as an incomplete breech, which is common about 10%, where we have one or both of the hips which are not flexed, so that the feet lies below the buttocks. So the hip are not flexed, so that it's possible for a foot to lie below the buttocks. So the cord and foot usually can prolapse, and there are risks in this situation. Okay, and then for management, usually is dependent on a lot of factors. So most frequently the delivery is via C-section, and frank breech with other local conditions may deliver vaginally, like we said. Then of course, if we have a successful external cephalic version, which is just a uterine manipulation to change breech presentation to a cephalic presentation, with a success rate of 65 or 50%, and the risks are placental abruption, fetal heart rate abnormalities, and reversion. Okay, then the optimal gestation age time for you to do an external cephalic version is usually 37 weeks. So that's the 7 weeks. So others is 35 to 37 weeks depending on the literature, but the reason why it's been put to near this time near term is because if anything was to go wrong, then of course you have to do immediate delivery of the fetus. That's why it's the optimal gestation age is usually 37 weeks for you to do external cephalic version. That's what I even said. it's now being discouraged, especially most in our setups. So because we have other better ways of delivering the fetus. Okay. Then methodology, of course, you have to use the ultrasound examination to confirm. So fetal orientation, placenta implantation, amniotic fluid volume, and to rule out anomalies. Okay, the other thing is you have to confirm fetal being by non-stress test. Then administration of SQ to relax myometrium. Okay, then you also have to monitor the fetal how the head is moved downward. Also have to discontinue if excessive discomfort is noticed. Also if there is a persistent fetal blood carrier. So if you don't have anything to monitor the fetal heart with, that's why people just don't necessarily do this anyhow. You need to have equipment to monitor or what we are talking about. So you have to monitor if there is excessive discomfort, persistent fetal blood carrier. Okay. Then administration of RH immune, or if the mother is negative because of the movement, which might cause the blood to pass from the mixing from the mother and the fetus. Okay, but of course there are contraindications. So we are talking about the ECV, the external cephalic version. So we've done the methodology. We can even talk about the contraindications. So contraindications, we can have if there is uteroplacental insufficiency, if there is hypertension, okay, if there is intrauterine growth restriction, there is oligohydramnios, if there is history of uterine surgery, if there is multiple pregnancy, if there is placenta previa or contracted pelvis, then there is no need for to do an ECV. Okay, then for complications of ECV, of course, we can have complications of ECV. We can have fetal maternal hemorrhage, we can have labor which might start, we can have fetal blood carrier, and even death can occur. Okay, especially if there is no proper CTG monitoring. Okay, so that's basically the summary on a breech presentation and also summary on ECV. And thank you for watching. And if you haven't subscribed, please subscribe and hit the bell notification. And see you on the next case study.